Welcome back, esteemed viewers, to the illustrious channel of the Nandi Empress, hailing all the way from the mesmerizing lands of Africa's Kenya. In our previous discourse, we delved into the realm of baseline workup for individuals newly diagnosed with the unyielding affliction known as tuberculosis. Yes, today I'm delighted to shift our focus to the intricacies encircling the management of tuberculosis, specifically those of distinctive nature. Allow me to expound upon these noteworthy considerations. Hospitalization, a consequential measure to be undertaken in select circumstances, is the first topic of our agenda. It is imperative to admit patients with tuberculosis to medical facilities in specific scenarios, which I shall outline for your enlightenment. Cases involving severe manifestation of pulmonary tuberculosis and extrapulmonary tuberculosis, such as tuberculous meningitis and pleural effusion. Number two, instances of severe malnutrition necessitating urgent medical attention. Number three, afflictions of severe pneumonia requiring meticulous management. Yes, guys. Number four, other concurrent diseases such as severe anemia, severe diarrhea, and their brethren. I know you understand that. Number five, individuals who have been mandated by the law authorities to ensure adherence to the prescribed treatment regimen. Number six, mitigation of inclement circumstances, namely severe adverse reactions like hepatotoxicity and severe cutaneous reactions. Yes, my people. Next, we delved into the realm of steroid therapy, a modality that has proven its worth in the annals of clinical trials by ameliorating the morbidity and mortality outcomes of individuals grappling with certain conditions, which include tuberculous meningitis, tuberculous pericarditis, and also tuberculosis related immune reconstitution, inflammatory syndrome in people living with HIV. For the effective management of tuberculous meningitis in our adult patients above the age of 14, the administration of dexamethasone at the daily dose of 0.4 milligrams per kg body weight, hand in hand with anti-tubercular drugs, is actually strongly advocated. The gradual tapering of the dosage over a span of 6 to 8 weeks is in order. On the other hand, prednisolone assumes the mantle of preference as the corticosteroid of choice in the other relevant scenarios. Allow me to expand on the dosage of prednisolone for both adult patients and children. Adults and children over 30 kilograms should be administered a dosage of 1 milligrams per kg body weight with a maximum threshold of 60 milligrams. That is for week 1 and 4. Subsequently, during week 5 and 6, the quantity administered should be lowered to 0.5 milligrams per kg, and during week 7, a mega dose of 0.25 milligrams per kg shall suffice. Yes. For individuals weighing less than 30 kilograms, the recommended dosage entails the administration of 1 to 2 milligrams per kg with a ceiling dose of 60 milligrams during the initial 1 to 4 weeks. Subsequently, during week 5 and 6, a reduced dose of 0.5 to 1 milligrams per kg body weight is to be dispensed. While for week 7, a dosage ranging from 0.5 is deemed necessary. Our journey through the intricacies of tuberculosis continues as we venture into the realm of treatment,
outcomes, and definitions, which hold paramount significance in the assessment, subsequent categorization of individuals undergoing treatment of these ailments. I shall explicate the various outcomes and their respective definitions. Cured. This designation befits a patient afflicted by pulmonary tuberculosis who had bacteriological confirmation at the onset of treatment and subsequently became negative or culture negative during the final month of treatment, as well as on at least one previous instance. Treatment completed is ascribed to a tuberculosis patient who steadfastly pursued and completed the course of treatment without any signs of deterioration. However, the absence of recorded negative sputum smear or culture results during the ultimate month of treatment and on at least one previous evaluation stems either from the non-availability of say test or their non-execution. Yes, people. What about treatment success? This amalgamation encompasses individuals who have been cured and those who have satisfactorily completed prescribed treatment regimen. This calculation is contingent upon confirmed bacteriological cases. What about treatment fail? Who is this treatment failure? This is a designation reserved for individuals with tuberculosis whose sputum smear or culture remains positive during the 5th month or any time thereafter, even while undergoing treatment. Yes, guys. What about an outcome died? This melancholy classification applies to individuals who succumb to the tuberculosis due to varying reasons, be it before initiating treatment or while undergoing the ADAS journey. What about someone who has been moved to category 4? This person is a patient who, while receiving the first-line tuberculosis treatment regimen, is confirmed to exhibit drug-resistant tuberculosis. What about loss to follow-up? These are individuals who regrettably fail to commence treatment or experience hiatus in treatment for consecutive duration of 2 months or longer. What about not evaluated? This classification encompasses tuberculosis patients for whom no treatment outcome can be ascertained. Such scenarios encompasses cases where patients have been transferred to another treatment facility, as well as those where the treatment outcome remain unknown to the reporting unit. Guys, I want us to look at the complications, TB complications. In these unfortunate circumstances, where tuberculosis is not detected early and accorded appropriate treatment, a plethora of complications may materialize. Permit me to elucidate upon potential complications. One of them is spontaneous pneumothorax. This is an aggressious occurrence whereby air infiltrates pleural cavity, subsequently hampering oxygen and ventilation. This perilous development arises from the rupture of a tuberculosis cavity in those close proximity to the pleura. It may further entail the formation of pus in the pleural space, leading to pneumothorax. How is the presentation? One shall encounter sudden onset of dyspnea and thoracic pain. How do you manage this case? Adequate hospitalization is requisite for the administration of apt course of action. A chest tube shall be meticulously employed, coupled with underwater seal drainage. Administering antitubercular medication is an imperative step in the context. Yes. We also have bronchiectasis. Bronchiectasis is chronic pulmonary ailment ensues as sequel to an infectious process, resulting in abnormal and permanently distortions of one or more bronchial or airway designated as conducting. The extrinsic compression of bronchi occasioned by augmented nodules may bring about bronchial dilatation distal to the obstruction. Progressive destruction and fibrosis of the lung parenchyma may further contribute to localized bronchial dilatation. Yes. What are the symptoms? Individuals shall suffer from persistent cough and copious expectoration, which primarily manifests as greenish, blood-streaked sputum with an unappealing odor, that bad smell. How is the management of bronchiectasis? The cornerstone lies with chest physiotherapy, encompassing the implementation of postural drainage and associated maneuvers aimed at ameliorating the clearance of respiratory secretions. Yes, people. Antibiotic therapy assumes prime importance during infection exacerbation, with broad-spectrum antibiotics such as amoxicillin clavulanate, metronidazole, or clindamycin utilized for anaerobic infections. Antipseudomonal antibiotics like ciprofloxacin and third-generation cephalosporin should be employed in scenarios where Pseudomonas colonization is suspected. Guys, let's look at lung fibrosis. This grave condition manifests as sequel of extensive tuberculosis disease, impacting long-term injury to the lung tissue. The placement of normal lung parenchyma with collagenous tissue culminates in alterations within the lung, such as thickening and stiffening of the lung walls. How are the symptoms? Individuals shall experience shortness of breath, particularly during exertion, along with chronic dry cough, fatigue, chest pain, and even diminished appetite. Let's look at the management of lung fibrosis. In case of severe and terminal lung fibrosis, resorting to long-term oxygen therapy becomes a necessity. A referral of proficient chest physician must be sought, and for selective individuals, lung transplant procedures may be contemplated. What about lung abscess? Guys, we have to look at lung abscess as a complication. This is a condition characterized by necrosis of pulmonary parenchyma due to microbial infection, most notably observed following severe lung damage resultant from tuberculosis. What about the symptoms? Affected individuals shall exhibit symptoms such as fever, productive cough, accompanied by expectoration of putrid or sour tasting sputum, night sweats, weight loss, anemia, chest pain, and hemoptysis. Management of lung abscess. Empiric administration of appropriate antibiotics in conjunction with the guidance derived from the gram stain and culture analysis of sputum becomes pivotal. Yes, people. Broad coverage for strict anaerobes and facultative anaerobic species necessitates the utilization of combination therapy involving beta-lactam, beta-lactamase inhibitor, such as ampicillin sulbactam. Yes, people. Yes, guys. We are still looking at tuberculosis complications. Let's look at massive hemoptysis. This dreaded phenomenon typically arises in the context of cavitary tuberculosis. The source of this life-threatening manifestation include the pulmonary artery, bronchial arteries, intercostal arteries, and the assorted vasculature that supplies the lung. The array of tuberculous vascular lesions encompasses pulmonary or bronchial arteries and thrombosis, as well as bronchial artery dilatation and Rasmussen aneurysm. How is the presentation? Observing the expulsion of copious amounts of blood through coughing becomes the harbinger of this condition, which is actually deemed life-threatening when approximately 150 milliliters of blood have been expectorated within a 24-hour period. The presence of airway obstruction, significant hypoxemia, or hypotension further adds to the gravity of the situation. Look at the management. The administration of Silate, aimed at masterfully curbing the bleeding, is actually recommended. In addition, a referral for bronchoscopy, skillfully executed by the chest physician, forms a pivotal component of holistic management within the condition. Let's also look at the chronic pulmonary aspergillosis, which is also a complication. This is a consequence of colonization of tuberculous cavities or bronchiectatic lesions by the fungus known as aspergillus. How is the presentation? Affected individuals shall exhibit weight loss, chronic production of cough, and recurrent persistent bouts of hemoptysis. These symptoms shall manifest in individuals who have previously undergone treatment of pulmonary tuberculosis. In addition, shortness of breath and chest pain may also become discernible. Yes, my people. Let us look at the management. Ascertainment of confirmed diagnosis is accompanied by examining serum levels, specifically immunoglobulin G directed against the aspergillus fungus. In light of this affliction, a surgical resection is a sole efficacious treatment modality available. As the curtains fall on our intellectual surgeon of the day, I extend heartfelt gratitude to each and every one of you, cherishing your precious presence. I implore you to consider subscribing to our esteemed channel, Nandi Empress, and eagerly anticipate your rendezvous with us during our forthcoming sessions. Until then, dear viewers, Kajas adieu. Thank you so much and welcome back another day.